Hi everyone, welcome to another seminar. We have the pleasure to have today with us Dr. Jenna Murray de López. She is an anthropologist specializing in reproductive health, maternal embodiment, and sensory ethnography. She's a lecturer at the Humanitarian and Global Health Institute at the University of Manchester, and she has done an amazing research on intimate relationships, Lifecourse in societies affected by violence, and she will be talking precisely about that in the particular case of Chiapas and Mexico. So, Jenna, thank you very much for being here. It's a pleasure to have you.
Thank you. It's a pleasure to be here. Can I just check that the volume is okay? And you can hear me? Okay, great. Okay, hi everyone. It's great to be here. So yes, as Gabby said in the introduction, I'm going to talk today about some work, the ongoing work that I've been doing in Mexico on obstetric violence. And this paper has evolved from nearly 10 years of me trying to get to grips with a very specific type of violence against women, not only in Mexico, but in hospitals and clinics across the world. The Lifecourse approach and the integrated ecological framework, however, are tools that I've been working with particularly more recently, kind of over about the last 18 months or so. I've been reworking my data and my writing and trying to find new and better approaches to work with the subject of obstetric violence. So I first explored their potential in a paper that's due out for publication in January next year, after an increasing frustration really of how the stories of maltreatment during birth were becoming more commonplace. Despite efforts, particularly in Latin America, but particularly in Mexico, despite efforts to legislate in order to protect women. So I was getting increasingly frustrated with activists and legislation and law work, really kind of highlighting and putting this question, this issue of obstetric violence and poor treatment in hospitals up there in the public eye. Yet at the same time, I was continuing to collect stories upon stories of women who were having multiple bad birth experiences in the hospital. So I had the intention of using that original paper as the basis for this seminar, and in many ways I still am. Yet, as with most writing projects, time passes and we become increasingly unsatisfied with what we were originally thinking. And that's kind of what happened to me after writing this original paper. And in my case as well, the really good constructive feedback that I had from peer reviewers and colleagues also has really pushed me to think a lot harder about the kind of things that I'm writing about. So in an understanding that my thinking has shifted somewhat, I've decided to use this seminar paper today to build on what I describe as an undercooked idea. It's still quite at the beginning, and that although I was able to write enough to turn out a research paper, I remain unsatisfied that I'm not doing justice to the women who gave me their stories over the years. So my original focus on the use of narrative in trying to understand violence in the context of childbirth and obstetric logic, I argued that women's life story style narratives, placed in the context of their transition to motherhood, revealed new ways to understand violence against women in a hospital setting. Now, my purpose today is to talk more in detail about the importance of understanding abuse and mistreatment during childbirth within the idea of a broader social ecology. Because I gradually realised that this is what women were doing when they were retelling their stories. And so this can be explored, I think, as ethnographic in method. It comes from the women's perspective. And B, through the process of presenting and discussing, I hope to gain some further clarity in my thinking and growth with this current project that I'm looking at the moment. So this as such, to be honest with this paper this afternoon, it's very much a work in progress, and I very much look forward to hearing any comments, thoughts and questions on the types of things that I'm going to talk about this afternoon. So before I go any further, I want to spend a moment to provide a few key definitions and contextualise my research as it currently stands. So I'm a social anthropologist and I specialise in sexual and reproductive health. My research methodology is in ethnography in its most classic sense in terms of a fieldwork method and a writing style. My work has been concentrated in the southeast state of Chiapas in Mexico for kind of on and off nearly 14 years now. I've been looking into different areas of women's lives and women's health and relationships and families and so forth. I carry out fieldwork in towns and cities, and I work predominantly in mestizo neighbourhoods, and I have a focus on low to middle income families. So dependent where I am, the main cities that I carry my work out in are the capital city of Tuxtla Gutiérrez and also its neighbouring city of San Cristóbal de las Casas. I tend to work with more middle class families, and when I'm in Tuxtla, and I've done my most long-term fieldwork I carry out in the low-income neighbourhoods of San Cristóbal de las Casas, in the barrios with the families there. So these are mestizo, mainly Catholic, large multi-generational families that I tend to hang around with and take stories from and spend my ethnographic time with and try and understand these women's lives from their own perspectives. So I'm mainly concerned overall in my research with female identity, intimate relationships and health. As a large part of this, I do have a specific interest in learning about the ways in which women become mothers in the urban context. So I'm always looking at a broader scope of women's health and beyond reproduction as well, and the different questions that come up from that. But the last few years, I've been very much focused on the notion of women's transition, at the different stages of life into what it means to be a mother in not just in Mexican society, but in mestizo society, and even more in the context of Chiapas society as well, which is also, you know, it's a very different experience to live in Chiapas than it is to say live in Chihuahua or Mexico City or Baja California. So the data that I'm going to draw from today mainly arises from fieldwork that I carried out for different periods between 2010 and 2013. And as I mentioned earlier, I work with women's narratives, kind of life story narratives. These are interviews that take place over a number of months. They last quite a few hours in their recording. And then I work very much with the narrative of a woman's whole life story to try and pick the connecting factors and the different things that happen to her. So maternal health in itself is a global concern. It's often cited as a leading cause of death in low to middle income countries, and it's therefore placed very high on the development and policy agenda of most governments. Now, Mexico's no exception to this. And despite actually, when you look at the figures, Mexico has a national maternal mortality rate which is on par with its northern neighbours. I mean, there's not that much difference between the maternal mortality of Texas than there is in the national rates of Mexico. And that means that the difference, though, is the vast social and health inequalities that we find across Mexico in itself, and that characterises a lot of Mexico. It means that in practice, although the national rates are actually faring quite well, the variance in maternal mortality across the country can be up to 13 times different. So the maternal mortality rates across the country, you know, vary massively. So this is also further complicated by the fact that although death at the moment of birth may be highlighted by global health approaches and by policy, as being improved. Mortality is improved by increased medical intervention is the main argument, and access to emergency obstetrics because of the main causes of maternal mortality, such as hemorrhaging being one of the main causes. What we tend to miss is the intricacies of what happens within those maternal mortality rates, and actually postpartum death, which is included in the overall mortality, but less attention is given to postpartum, as in the days, the hours, days, and few weeks after birth. Mexico is in quite a special place in the world, in an unfortunate sense, that postpartum death is actually something that's on the rise in Mexico. So where the overall maternal mortality rate and women dying in the moment of birth is very, very slowly coming down, the postpartum death rate is actually rising. And this is a possible indication that this increase in intervention at birth is having unforeseen consequences in the days and weeks after. So the numbers of C-sections and the other types of surgical interventions that are happening in birth, there's actually indications that what's happening is that women are dying from complications due to interventions in the days and early weeks after giving birth as well. So through its numerous national and state development plans, currently Pro Igualdad, which is the 2013 to 2018 main national development plan, the Mexican government has made improving maternal and infant health a priority. And this manifests in various different ways. Now, one key approach, although evidence is increasingly showing this is not actually a reliable indicator, as I've already mentioned, is increased access to prenatal care and emergency obstetric care. Now, what myself and other anthropologists and social scientists researching in this area argue is that where there is no indication of quality in the provision of those services, there can be no or little evidence over whether or not they are actually beneficial to the women that access them. So there's a real question about equity and quality here. And we are starting to begin to see that reflected in the sustainable approach to health and the sustainable development goals that were recently introduced in 2013. Now, institutional management of pregnancy and birth in urban Chiapas and in rural Chiapas is legitimately preoccupied with high maternal and infant mortality. Chiapas has the second highest maternal mortality ratio in the whole country and the highest infant mortality nationally. So the state also has the highest incidences of underage marriage and also the highest rates of adolescent pregnancy, along with the associated health risks that come along with that, and also the different levels of structural kind of violence and inequality that are associated with younger women having babies. Now, the most recent National Mothers Index, which was a study carried out by Save the Children in Mexico, identifies Chiapas as the most challenging place to become a mother because of all the inequality and social factors. And the interesting thing about this report as well is they actually make a point of saying that it is one of the most challenging places to become a mother, regardless of ethnicity. So this is not just a focus, which happens a lot on the maternal mortality rates, where we get taken into the kind of Indigenous women and women in rural areas are kind of framed as the cause of a lot of these maternal mortality rates. It's actually changed. It's changing quite a lot with the rapid kind of structural and economic growth and large-scale social changes over the last few decades, that actually the rural and urban situation in Chiapas is not that different in terms of mortality rates and in terms of social health inequalities and access to public services as well. So pressure to react to such a highly publicised data, also to meet the aims of the international and the national development programmes by 2018 and 2030, matched with the actual reality of high maternal mortality, means that the level of obstetric cases dealt with in the public hospitals of Chiapas will shape the societal and clinical attitudes towards the perceived dangers of childbirth overall. Now, my experience with both public and the private hospitals of Chiapas is that childbirth equals an emergency. So when you speak to people within a medical environment, and then from that to how women talk about their birth as well, is that childbirth is seen within that institutional context as an emergency event. It's a question of life or death. And in this way, maternal health becomes framed by a clinical rhetoric of saving lives at any cost. Death for a medical practitioner is synonymous with failure. So it's something they want to avoid at any cost. And it's something they feel a lot of the time their actions are about preventative medicine. And the thought that something might happen, so they'd rather intervene before it does. Now, this is in direct opposition to the way in which women often speak of pregnancy and birth. And they speak about pregnancy and birth in the social context as the creation of new life for both mother and child, the idea of being reborn for the mother and the idea of being born for the child into the world. So the treatment that women receive in healthcare services also contributes to shaping their experience, and on top of that, it kind of conflicts and begins to provide a different vocabulary with which they begin to talk about maternity. Now, a woman will describe her pregnancy and begin to talk about her pregnancy and birth in the terminology used by the medical professionals that she comes into contact with, and this securely anchors her reproductive experience in a particular political, cultural, and historical moment in time. Now, to be brief, it's generally accepted in maternal health research that the prevalence of bodily violations and coercive behaviour in hospitals across Latin American countries is very much congruent with this rise in access to healthcare and institutional birth. It's almost kind of suggested that it's an unintended consequence of increasing women's access has been an increase in abuse and poor treatment. You know, there are many complex reasons as to why this happens. There is increased access to institutions and birth care, but there's not necessarily an increase in the level of resources that are there to provide to women. So hospital staff are working under great pressure. They're working under circumstances of having very little resources, both practical, physical, time management and you know, workforce wise, and this all kind of comes together within that environment and that stressful moment of birth to not excuse some of the acts that happen, but you know, to begin to unpick some of the causes of why some of these things might come about. Now, beyond Latin America, the World Health Organization has also declared the mistreatment of women during childbirth and associated human rights violations as a global problem. So this is not just a Mexican thing, it's not just a Latin American thing, it is a global issue in high and low to middle income countries. The issue was further highlighted in 2015 as UN and regional human rights experts issued a joint statement explicitly calling on states to address, and this is their words, in acts of obstetric and institutional violence. So here we start to see an entrance over the last 2 years within global policy of the language change as well. They are naming obstetric violence and they are naming the institution as a source of these kinds of acts. Now, despite this international and regional standards on abuse and the mistreatment of women both during birth, this still remains in an early development in terms of the tools, the education and the policy ways and legislative ways of how to deal with this. So what do I mean when I use the phrases obstetric violence, abuse and mistreatment? So obstetric violence is a product of a multifactorial framework where institutional and gender violence overlap. It's a form of gender-based violence precisely because it is done to women as gendered subjects because of who they are in terms of they are biological reproducers and because of what they represent. So what I mean by this is that they represent moral subjects within that society, a certain type of moral subject that has had sex, got pregnant and must be seen to behave in a certain way in terms of the life. So she's not in the moment of birth seen as a mother, which is something that, or someone that's about to become a mother, which is something that will happen in the out of hospital context, what she's seen as a moral subject who has done something. She is the proof of the relation of, you know, the sexual act out there in public, because the result of which has been a pregnancy. And the way that a lot of abuse happens is actually targeted at the woman from a very moralistic point of view of who she is and why she's there and the reason why she's there in the first place. So obstetric violence violates women's reproductive health rights. It results in physical or psychological harm during pregnancy, birth, or postpartum. And perpetrators of obstetric violence can be lead clinicians, they can be obstetricians, but they can also be nurses, student doctors, and other kinds of support staff that are around. And this is regardless of gender as well. Obstetric violence earned its name because it happens within the space of what I can call obstetric logic and obstetric practice. So this obstetric logic, what I mean by that is this idea of emergency, panic, life or death. Obstetrics as a medical practice comes out of a need to deal with emergencies, not a deal to manage childbirth, but obstetrics itself is an emergency practice. That's where it has its roots within medical practice. So manifestations of obstetric violence can include the direct abuse, such as scolding, taunts, irony, insults, threats, humiliation of the woman, manipulation of information, and the denial of treatment if she doesn't or do what the doctors or the nurses wanted to do, and also coercion to obtain consent for invasive procedures. So there's coercion in a moment of vulnerability, in terms of signing the papers to allow a C-section to happen, or to have contraception inserted straight after birth. It's a kind of the type of threats that happen directly to a woman. But we also have systemic acts of obstetric violence as well, and these can manifest in high rates of cesarean sections, routine practice of episiotomy, which I think generally in Mexican public hospitals you're probably talking within the 90% of practices of episiotomy, and actually it's only supposed to be used as part of an intervention if there are complications in birth. It's not supposed to be something that happens all the time. If you're wondering what episiotomy is, if you're not quite sure, it's when the woman is the opening of the vagina is cut to allow more space for the baby to come out. It's not something that's necessarily needed when time and the right kind of support is allowed for birth. It is an emergency kind of intervention. So routine manual examination of the uterine cavity during active labour is also a systemic act of obstetric violence. It's something that becomes the norm in medical practice. It's known kind of more commonly as el tacto, and this is something that also shouldn't happen to women while they're in labour as well. So it's something that's particularly commonplace in the underfunded public institutions of Mexico, but I wouldn't go as far as saying this is just a public health, a public institution problem. These kind of things happen in many private institutions as well. So in Mexico, there's a disparity between the number of states willing to adopt legislation against it. Against obstetric violence, and there's also an unwillingness to relate the phenomena to the broader context of socioeconomic, ethnic and gender power relations, further complicated by cultural dynamics and attitudes to what constitutes gender-based violence in the first place, and what violence is, and what is just simply necessary emergency medical practice. So over the last decade, there's been an increase in empirical and systemic research on the issue in Mexican public institutions. Yet this remains fragmented. Research tends to focus on systemic failure and the attitudes of medical practitioners. Above all, outside of activist networks and NGOs, there's been very little attempt, from what I can see and in what's been published, to understand how women interpret the violations they experience at the hands of health professionals, and more importantly, about how it impacts on their notion of self and their general being in the world. So this is something I keep coming back to. this disconnect for me between research, policy and everyday life. I once heard anthropologist Vina Das say that once an issue becomes policy, only certain types of evidence are seen as legitimate. Now, with the issue of obstetric violence, evidence is drawn from what can be observed, rather than the testimonies of those who are subject to it. So the evidence comes from researchers who are observing these things. It comes from interviews with medical staff and the kind of the outside. So people are looking around the woman rather than listening to what she's saying. And women do find platforms to speak about their experience. They use blogs. Last year, an organization in Mexico of women's reproductive health rights held a symbolic tribunal where women were invited to an audience of reporters, journalists, activists, and they gave witness, they gave statement to what has happened. They do have somewhere to speak, yet at the same time, very little is changing. And what I'm beginning to think about is that the problem may be with what research has been focusing on and the context within which obstetric violence is also analysed. So we keep doing the same things when we're researching obstetric violence. And when we have a look at that alongside the fact that within 25 years worth of focus on this subject in the Mexican context, very little has changed, and in some respects it's getting worse. We do need to start looking back on ourselves in terms of how we're carrying the research out and what kind of questions we're asking. So for the purpose of the discussion today and the title of this paper, I'm using the term iatrogenic trauma. So iatrogenic is a phrase that you use for an issue that has been caused by a medical practitioner or medicine itself. Because my exploration is on the impact of mistreatment within the broader context of women's lives. So by taking what I call a critical life perspective, my aim is to consider how brief yet powerful acts of violence go on to shape how women feel about themselves, how they view themselves as mothers, how they manage intimate relationships, and moreover, from a health management perspective, how they negotiate interactions with the health professionals throughout their lives. So ultimately, this more long-term way of thinking about not only the act, but the consequences of what is commonly termed obstetric violence is in an effort to re-centre women and their voice and their experience, to try and listen to what women are saying and the things that happen to them at pivotal moments of change. So in another project that I work on in the UK with a colleague of mine here at Manchester is alongside female asylum seekers subjected to reliving their trauma on a daily basis as they perform their role of victim in order to gain legitimacy in the asylum system here in the UK. So these are women who are constantly made to retell their traumatic stories over and over again in order to legitimise their status as asylum seekers as opposed to migrants in the country. And I'm often gifted with nuggets of inspiration from these conversations that I have. A few weeks ago, I was attending a regular drop-in session run by and for the women. And I was asking the type of banal, misplaced questions one often does during fieldwork. And I've been trying to find out what women felt they were most deprived of as asylum seekers in the UK. And one woman, she just said something really quickly, but it's something that stuck. She turned to me and said, we have so very much on the surface and yet so very little. We do have various platforms, and as asylum seekers, we have a voice, but no one is listening. And that's something that really stuck with me when she said that. You know, it's this idea that we come forward with these approaches, with these ideas that, you know, we're going to put these issues out there, you're going to talk about it, and you can allow those spaces to happen, but actually the challenge is getting people to listen. And that's the last part of her sentence which really struck a chord and has stayed with me. And especially when I think about the things I've been trying to understand in my research on mistreatment and iatrogenic trauma in Mexico, the frustration I've been having with a phenomenon that receives a good amount of attention after 25 years, it certainly does, yet nothing seems to change. Is it because those who are able to do something are simply not listening? So in my efforts to write about this disconnect from an anthropological perspective, and by disconnect I mean the ways in which state activists speak about human rights and gender-based violence, juxtaposed with how women speak about their childbearing experiences, I found in my research that women are aware of what should happen to them when they go into hospital. They're perfectly aware of their rights. They're perfectly aware of, you know, what should be going on, and they're also aware of what does happen through the stories that they share amongst each other, through the experiences of other women in their family, and also through experiences they may have had themselves with their first children. And they do have many strategies for trying to deal with these consequences. The way in which women can be treated in the delivery room is not something that happens in a bubble. It's intrinsically connected to societal attitudes about gender, childbearing, medicine, class, ethnicity, and from my observation in the case of Mexico, even nationhood. The prepping of women for this complete loss of power begins even before the egg is fertilized. It's cemented during prenatal care, and it comes to fruition in the moment of birth. The current system and culture is such that women are not in a position to challenge abuse as it happens. They're often alone due to institutional constraints in public hospitals. Many women cannot be accompanied while they're giving birth. They are overpowered by medical hierarchy and threats to life, and they are physically unable to move. And ultimately, they are in labour. They are giving birth. They are not in a position to start having a contretemps with an obstetrician. So this means that much of the processing of violence for many women is done in the days, weeks and years afterwards. And it can and does have a significant impact on who they become and how they live their maternal lives. Now, my critique on current research is that it focuses on the moment of the act and who is carrying out the act. There is a gaze cast over the situation and the women within it, but it's treated as a contained thing that begins and ends in the medical environment. When I speak to women who've been subject to different types of extremes of abuse, it's only after a while, it's often after a while that it's happened. So I speak to women within the space of a year, sometimes up to 5 or 6 years. So they're reflecting on what's happened to them. It's a memory that stays very raw with them, and it comes out through their memory, their emotional memory as well. And they situate the mistreatment within narratives informed by expectation and desire. They often focus on how they were feeling in the months leading up to the birth and how they prepared for change. Through traumatic experiences at birth or sometimes during pregnancy, they describe how expectations were crushed, how fear of death took over feelings of happiness. They focus on and make comparisons with how their bodies are given to partners and children to prevent further pregnancies and dilemmas of whether or not they could ever go through it again. It's one particular aspect that springs out of my data more than anything, is the need to reconcile a few hours of abuse with a lifetime of every day getting on with things. So during interviews with women, midwives who often support women, the midwives who are often supporting women through follow-up pregnancies as well, outside the hospital system, some comparison can be made with narratives, I think, of sexual abuse in the way that women go on to think about and struggle with their bodies then throughout their lives and contextualize it and work with their memories and their experiences to go through the other roles and purposes that they have. And for me, it's important for this reason that when I turn to wider theories of gender-based violence as a way to deepen understanding of obstetric violence and de-isolate it from the problems of institutions. Firstly, I think what is needed is a better way to understand the women who are subject to mistreatment and abuse beyond the critique of medicalisation of childbearing. It does not always come down to the fact that medicalised management of childbirth is wrong and will result in violence, and it just ends there, because this keeps it within the institution. And also, secondly, an approach that can help us think about the longer term impact on their lives, because from an ethnographic standpoint, women connect events to how and who they are throughout their lives, and this changes. So I'm going to move kind of briefly and in the latter part of my paper now to the two approaches that I'm using to help me think about this. And firstly, I'm just going to talk about the Lifecourse approach, which is really helping me think consider and flesh through these ideas about how women take their experiences throughout life with them. It doesn't determine who they are, and it doesn't follow a linear negative path. But this idea of the life course approach allows me to speak to some of the research questions that I'm asking. Now, from a life course perspective, it is seen as common and understood that to try and understand a person by looking at the way that to try and understand a person as a whole, you do this by looking at the way that a person has developed throughout different periods of their life. As our life stories unfold, we are shaped in specific ways in which we are neither separate from our environment or our past, yet neither are we wholly determined by our past. There is levels of agency within the life course approach and way of thinking. At its most basic, the life course approach wants us to explore ways in which twists and turns of life events impact on individual and family pathways. In order to understand a person, you need to look at them as part of an integrated system. Now, it has its origins within medical anthropology, so I am quite biased towards liking this as an approach and a way to think, but it's also quite critical as well. It's been further informed and is very much used in areas of medical sociology, social history, epidemiology, and very much in development psychology as well. So it's very much an interdisciplinary approach. So it's useful for devising questions in anthropology and for an ethnographic approach, but it also draws on other disciplines. And I think what's useful about that is it allows me as an anthropologist to engage with other disciplines working in the area of maternal health and have very good open debate and conversations about what's going on here, and try and think about it from the perspective of other disciplines as well. So I don't wish to dwell on the core aspects of the life course perspective, which is very much about transition, ideas of trajectory, life events and turning points, all these different twists and turns which allow us to course through our lives at various different speeds and rates and in different directions. So like many anthropologists before me, I do take issue with the more traditional and culturally bound linear approach to how life course plays out in disciplines such as development psychology is kind of one example. So I've taken to prefixing the word critical to the title of this approach, and what I'm trying to develop at the moment is a critical life course approach, in the hope that it forewarns people that I will be using its ideas in a way that takes on board and simultaneously challenges the concepts that it employs. A critical life course approach looks at points of interaction between recurrent patterning of social life, its disruptions and individual processes of change. Now, one anthropological critique of the life course proposes a complete rejection of this idea of life stages that comes from development and ideas of human development, that we're at stages from birth, from toddlerhood to childhood to adolescence and so forth. Now, there's an anthropologist called Jennifer Johnson-Hanks, and she wrote a very interesting proposal back in 2002, where she uses fluid transitions to motherhood for women in South Cameroon to show how, rather than specific and transitional life stage, becoming a mother for these women is actually a temporary social status, one that is evoked by specific forms of social action. Now, I found quite a similar example in my own work in Mexico. So whilst great celebration in Mexico is made from my observation of a woman's first child, when she gives birth for the first time, she is legitimized by the state as a mother, and she is therefore eligible for welfare programs. She has this legitimate role in the eyes of the state. She will be celebrated by the sponsored frivolity of Mother's Day once a year. You know, she has this mother hat on it in certain spaces. Yet in the multi-generational homes that many lower and middle income mestiza women live in the cities of Chiapas, in terms of my fieldwork, the woman is very far from the role of experienced and accomplished mother, let alone a fully fledged adult. something rarely acknowledged actually until grandparenthood. Motherhood, particularly in so-called mother-centric societies, which a lot of Latin American countries have kind of come under this label, is often conflated with crossing the threshold into adulthood. It's often argued that one becomes an adult in mother-centric societies by giving birth and having a child. Yet in many of these societies or cultures, it's actually a temporary status awarded at the moment of giving birth, and in certain spaces. It's very quickly reversed in the case of Mexico before a woman even leaves the delivery room. Even straight from giving birth, she's often chastised and infantilized by doctors in regards to her expression of emotion or decision making. So even in that moment where the child is present and she supposedly becomes a mother, it's quite often the role is shifted even within those first few moments. It's not as clear cut as a smooth transition. Now, there's a suggestion that's made as well by Johnson Hanks about life stages as concrete transitions that emerge only as a result of institutional projects. And this is useful for considering the ebbs and flows of maternal identity as intrinsically connected to past and possible futures. It moves away from the troublesome notion that once an event has happened, one should simply move on in a linear forward-facing trajectory onto the next loosely defined stage of life. And this is something that's often said of, by, and to women in the postpartum period. You have your baby, you're happy, whatever's happened, forget about it and move on. And this is often used as a strategy for dealing with the unsavoury notion of abuse in the delivery room and the acceptance that the body may have been violated in ways deemed acceptable via medical discourse. Now, the critical life approach, which incorporates disruptions to patterns as well as social ecology and determining factors, is one way that we can understand the impact of iatrogenic trauma. Now, what I'd like to do now is move on from the idea of a perspective, a way of looking at women's lives as across a life course, and the way that the past moves into the future and so forth, a very abstract way of thinking, is actually to look at a practical tool to be able to use this within a research environment, within research practice. Every perspective needs a tool that can be applied. And this is where I move into an integrated ecological framework for analysing gender-based violence. This is where this comes into my discussion and works quite closely with the idea of the life course. So where the life course gives us a way to think about the precursors, disruptions and long-term impacts of obstetric violence, the ecological framework that we can see here provides us with the tools to think about how it comes about in the first place, what the wider social and community determinants may be, and what the potential strategies and coping mechanisms are likely to be. Now, the ecological framework that's shown here is something that was developed by a woman called Laurie Heiss in the late 1990s. It's a well-cited paper by sociologist Heiss, and she provides a cross-cultural analysis of the factors that influence the likelihood of violence against women at different levels of the social ecology. And she argued that despite decades and decades of activism and research into violence against women, there still remains no actual consensus as to the social causes of gender-based abuse and violence against women. So she presents this as a research tool, and it's a framework that integrates findings related to all types of physical and sexual abuse of women to encourage a more integrated approach to the theory building regarding gender-based abuse. And her work aims to get at the root causes of gender-based violence in a given society, incorporating the institutional, structural, social, community and individual factors, and to think about the perpetrators as well as the victims. It's been used and adapted widely to think about risk, vulnerability, and the likelihood of re-victimization as well. And when I came to Heiss's work, I began to envisage it as a tool for exploring the right kind of questions of obstetric violence. So I see it as a way that I see it as a tool that can be applied to existing research to try and analyze what questions are being asked and what we're missing, more importantly than anything else. It's a way to consider caregiving responsibilities and practices, generational gender inequalities, personal history and cultural expectations of gender roles and intimacy, and how these play in to the different levels and different types of inequalities and violence that plays out in the wider society. And most importantly, it can be used to address the disconnect between women's narratives and the fragmented research. Now, I'm certainly not the first person to combine these two approaches to health and violence, and I would never claim to be. But what I observe in my research is a problem with obstetric violence being absorbed into wider anthropological and social science understanding of gender-based violence, and at least not in any clear way. So it remains separate. Obstetric violence remains something outside of the wider study of violence and gender-based violence in society. And this ultimately impacts on the success of any strategy to deal with its consequences. I could argue that this is similar to other kinds of birth trauma across many cultures, and it may be because of the political, medical environment within which it takes place, makes it difficult or uncomfortable to deal with publicly as a gendered and sexual form of violence, which is ultimately taking place within the medical environment. Now, the right to live or die, receive respectful medical care and have autonomy throughout pregnancy, birth and postpartum are heavily loaded concepts when so much is at stake politically and professionally in terms of the practice of obstetricians, in terms of health policy and goals that need to be achieved in terms of mortality rates. And what I've seen throughout my research is one of the main problems which keeps taking evidence to practice rather than the subject and her attempts to navigate a happy and healthy life, despite and in spite of what she has to confront in the process. So what I'm trying to present here ultimately and to conclude is an alternative way in the way that we begin to look at violence within hospitals and mistreatment of women, and that we start to really recenter the woman to find out what's actually going on and how this impacts her throughout the rest of her life and the generations beyond.
Jenna, thank you very much. I was trying to sort the questions out because I think we have 3 sets of questions. First set related to the context of Chiapas and obstetric violence in Mexico in particular. The other one on the role of social anthropology to enable public policies change and so on. And a third one on methodology. So I will try to organize them as much as I can. First, regarding context, one question is the impact of culture and certain ethnic backgrounds in the narratives of these women. Like if you have perceived that certain cultures tend to be more present in the narratives or not. Another one is related to the latest news on how Chiapas has hospitals that are not operating, that they serve as kind of political tools, but they are not actually hospitals working. And if you think that has an effect, a disproportionate effect more on women and mothers to be, that it has to other groups, then we move slightly to how social anthropology can, if it can actually change public policies. This question was related to what it can do and how we can use ethnographies to at least provoke discussion between policymakers, particularly because you were talking about this disconnection between research policy and life of individuals. If you think, another question was, if you think obstetric violence is focusing the race, in race awareness efforts are focusing on women, which is often the case with other gender-based violence, the other types of gender-based violence that focus on raising awareness among the victims, or if you think that obstetric violence is focusing more on the perpetrators. The efforts are focused on practitioners, medical personnel, and so on. And finally, we have some very interesting methodology questions. One is related to the challenges of discussing life stages and identity, and how do you approach perceive overlaps in these women, and how you can differentiate the stages. Another one is how do you make sense of everything that confirms the memories, that it could be either traumatic or not, but because it's a mix of facts, feelings, emotions, and self-interpretation. And finally, how do you think it's a good way to approach data to rethink about it? And I think this is related to what you were discussing at the beginning, that this was something that you thought you already have a grasp of it, and then you look back and kind of took up a view about it again. So some advice on the best way to do that.
Okay.
you can answer
right,
as many as you.
Okay, I shall do my best. I'll go back. These are really interesting questions, actually. I'll start with the kind of context of Chiapas and obstetric violence, and the question about ethnic background and obstetric violence as a practice in Chiapas is a very interesting one, because I think if we go back to the tool of what I was talking about at the end of my paper, of this ecological framework, if we have a look using that framework as a way of measuring almost kind of who is likely to be most vulnerable to acts of obstetric violence, then yes, we could very much argue that very poor, very low income, particularly Indigenous women, particularly migrant Indigenous women or migrant Central American women as well, who are working their way through, which you find a lot of women, a lot of people movement you found Chiapas. These are women that are particularly vulnerable to forms of violence in the public health system, due to language issues, due to issues of oppression and racism in society, and assumptions that are made about women into their bodies. It's definitely a big issue. Ethnicity plays a large part. It definitely does. What I also find, though, is that not being Indigenous does not give you kind of exemption from the violence either. So we have this crossover of ethnicity is one factor. Economic background is another factor, because your economic background will also decide what kind of services you're accessing in the first place. You know, if you're on Seguro Popular or Prospera, you are accessing a certain type of hospital. And the economic factor hits mestiza women and Indigenous women in similar and very, very different ways. And actually what I found, and something that I found with middle class mestiza women as well, are the types of assumptions that are made on mestiza bodies that are based on class and economic background as well. So you'll have this idea that Indigenous women are treated as uneducated, poor, they don't know what's good for them, they're going to have too many children, so if we give them a C-section, then we can sterilize them without their consent, and we'll stop them from having more babies, because there's an assumption that all Indigenous women are being abused by their partners, which is just not true at all, and they are capable of making their own decisions. But then you also have assumptions made about whiter bodies, and I suppose I mean white bodies in the sense of class and non-Indigenous, that lots of doctors and lots of women report, and doctors will say to me as well, that mestiza women's bodies are not made for childbirth. That childbirth is something that Indigenous women do. Their bodies are made for it. They're small, they do lots of it, it's generational, it's fine. And what you find with a lot of middle-class women is that they will be told that they will not be capable of giving birth, because it's not the kind of thing that a refined woman does. Her body isn't made for it. You won't be able to cope with the pain, and also, why should you cope with the pain? So actually what we do have there is some interesting questions about ethnicity, because it's ethnicity in the sense of mestizaje, and it's ethnicity in the sense of indigeneity, and they have their different things. And what's interesting about obstetric violence as a form of violence, very much in the way of how we understand sexual violence and domestic violence as well, is in many respects it cuts across class and ethnic divides, because of where it's coming from in the first place. So my answer to that, whether it's helpful or not, is kind of yes or no. Yes and no, in that yes, there's very much a vulnerability provided by a woman's social and ethnic background, but it doesn't define whether, you know, the ways in which she's definitely going to be subject to forms of violence. Now, hospitals not working as hospitals in Chiapas, that's a really interesting one, and it's not actually a new thing either. When I was pregnant with my first child in 2007, this will have been, I had no health insurance at the time, and I hadn't found a network of midwives that I eventually found working in around San Cristobal, and I was accessing it was then Oportunidades. So I was accessing an Oportunidades clinic. I had my little red Seguro Popular book that I used to go and do my prenatal appointments and so forth. Now, at the time, the clinic that I used to go to was half under construction. It only had an obstetrician visited once a week. It had one sala de expulsión. It didn't have the tools to do an emergency intervention like a C-section, and so women would have to be transferred mid-emergency to somewhere else to have a C-section. Yet the hospital was shown from the outset as somewhere where women with low recourses could go and have their child. So hospitals not working as hospitals is definitely not a new thing in Chiapas. Under-resourced hospitals is definitely not a new thing. There is very much a political agenda there. There is very much an idea of ticking boxes, especially in terms of the reach of the kind of the Prospera programme, and since more recent governments as well. They're on a lot of campaigns. There's a lot of caravans to do with the end of everything. You know, it's the caravan to end poverty, the caravan to end hunger, the caravan to end maternal death. They're all off on a crusade, which is quite interesting and has quite religious and political overtones. My short answer to that is yes. There's a big political thing going on there, and it's not helping women in the slightest, because when they're signed up to welfare programs, they are obliged and coerced and have to attend birth. They have to give birth within specific named public institutions. They have no choice. Otherwise, it impacts on whether or not they can get their welfare benefits afterwards, and it impacts on whether they get their vouchers or whether they get their food, and also whether they get the free education for their child. And most specifically as well, it impacts on whether they can even get a birth certificate and legitimate the citizenship of their child. So yes, it's very bad for women because they're forced to go to places that aren't equipped to look after them. In lots of cases as well, or they're forced to get in debt to find the money to pay to go to other places. So that's my answers to those. In terms of social anthropology, and can social anthropology change public policy? I would like to think so. I think but on a practical level, it comes back to a point that I made in my paper, actually, is that as anthropologists, as public health academics, yes, we have a lot of platforms and we have a lot of opportunity to wave our qualitative flags and say, look, you know, we need to start incorporating these kind of things. Whether anybody is listening is another question. You know, I think that's a really important thing, is that actually the acknowledgement of qualitative data, the acknowledgement of the anthropological ethnographic perspective isn't just something that they say they've done and then they don't do anything with. There are a lot of medical anthropologists working on this subject in the movement of critical global health within anthropology. There is an amazing woman called Binkani Adams, and she works on projects of alternative accounting in global health. And she's got a brilliant edited book called Metrics, which looks at exactly these ideas. And she makes lots of arguments about how practically medical and social anthropology can impact on public policy. And she argues very much for, rather than us having lots of quantitative kind of number crunching, random controlled trials and approaches to medicine, is that what we need to do is begin with ethnography first. So ethnography isn't something that's thrown in as part of an already existing research method, that actually what we should do is begin with ethnography and understand what the actual localized important research questions and priorities should be from that qualitative perspective, and then we can go on to do better quantitative interventions and research from that. So she makes a good argument for that. We've also, in terms of maternal health, there is a policy document, a really good policy document that you'll find on the World Health Organization website, and it's called Optimize. It's Optimize for maternal neonatal health. And in this document, which was put together with an advisory board which included an anthropologist, there are very clear statements about the World Health Organization's support of qualitative data and evidence, and that we do need to be working in more and incorporating a more qualitative approaches in order to get through to this idea of equity and quality of services. So, you know, the intention is there, is what I'd say. You know, the impact that it has, you know, we'll see over the years. I think the question around the awareness of the effects on the focuses of women or perpetrators. Okay, so what I was trying to say in this paper is actually one of the problems that I think there is that there is too much focus on the perpetrator. There's too much focus on the perpetrator and the systemic causes. So that what it does is it becomes a contained act, is kind of what I was saying in the paper as well, is that it happens in this medical bubble. And what gets lost within that is that almost kind of, in some ways, the obstetrician stays within that medical bubble. They don't leave, you know, them and their practices stay there. Whereas the woman leaves hospital, she goes out there into the world, and there is very little attention put on what happens to her afterwards and how she feels about it and the healing process and how it goes on to impact. So what I would say is that there's not enough focus on women, or the type of focus that's there isn't doing the right job. So there's testimonial, you know, there are, you know, there's activism, there's blogs, but it's not getting to the right people, and it's easily ignored by politicians who are choosing to ignore it. So I think, yes, we need to understand the systemic causes. We need to understand what's going on in medical practice, but we need an equal yet different approach to understanding what's happening to women. Methodology. Okay, the challenges of the life stages approach. Yes, what I would say, and I didn't kind of, I was aware of time, so I didn't want to start deconstructing it too much, but the kind of the anthropological critique to the Lifecourse approach is this element of life stages within it, this clearly defined stages of life which is very much connected to developmental psychology, is actually something that's argued within anthropology that is done away with, really, and that it's not helpful because it's very it's something that's socially and culturally defined as to what a life stage is. It doesn't mean that life stages don't exist within different cultural ways of thinking, but then what you have to do within your fieldwork and as part of your methodology is find out what the ethnographic understanding of a life stage is. So how do people measure life stages themselves? So in the UK context, life stages are measured by age and actions. That's not necessarily what you're going to find in other cultural contexts, but elements of what a life stage is there. You just have to find out what it means from an ethnographic perspective, and you need to incorporate that into your analysis and explain it. And also focus on process rather than a stage, so that it's a fluid thing that can move back and forward, and it's not you hit a stage and then you can never return to it. The use of memory as a method is a really interesting one, and I've written about it in other places as well. And I'm really influenced by the work of a British sociologist called Anne Oakley, who does a lot of work on motherhood in a British context, and she writes some really interesting stuff about memory. And although what I always declare when I am trying to work and present narratives that are based on people's memories of what has happened is that what we're dealing with is that person's truth at that point in time, and I don't think you have to go any further than that. You know, I think you have to acknowledge that a memory is very real for the person that's talking about it. And even if we're there at the time that something happens, you know, if you go out with some friends for a drink on a Friday night and there's 5 of you there and certain things happen, conversations happen and so forth, you will wake up on Saturday morning and you can have 5 different accounts of what went on that Friday night and 5 different perspectives, even in a conversation between 2 people, you know. So I think exactly the same, we can place the same kind of questions on dealing with something happening in the here and now. It's all down to a subjective experience, and that's what memory is as well. It's an interpretation, and it's just as important as what actually really happened, which is why a lot of the time when I try and write about this, I try to go to great pains to explain that what I'm not doing is questioning the actions of the medics, because I wasn't there. I am not the doctor who made those decisions. They have their own justifications for doing what they did, and I am not there to question that. What I am there to do is try and present how the woman saw the situation and how she understood it and how she remembers it and how it impacts on how she is as well. I don't, what was the last question was about advice on, I've got advice on the best way, and then I've got blank.
On how to approach data that you work previously with that it's not quite recent, like how to rethink data that you collected a long time before.
Okay, that's a good one, and I just think it's the same as going back to a favourite novel that you read a long time ago and that you read again in later life and you learn something new from. And you learn something new from going back to old data all the time. And this is very much steeped in the approach of reflexivity that you have in the anthropological approach and in doing ethnography, is that each time we go back to that data, we ourselves are in a different position in life. We have a different experience, we've learned something else, there's something new that can be put onto that data. And that's the enjoyment that I find in the type of research that I do, and in the qualitative approach to research itself as well, is that at no point are we saying this is a general fact that will stay the same forever. We're just presenting how something is now. And I really like going back over years and years worth of data, as all anthropologists do, to see how my thinking has shifted and also how things have changed itself. It's always interesting, I think, the benefits of doing long-term ethnographic research, although there's very, very little money in it, it's very difficult to do, there's no funding whatsoever, but is actually having the opportunity to go back to the people, you know, that you've done research with. So I have interviews with people, you know, I've got recordings of people that I interviewed in 2009 and 2010, and I will periodically be able to go back, you know, and they listen to the interviews themselves and they don't recognize who they are, and we, you know, that itself evokes another conversation. And yeah, it's what isn't spoken about a lot, I think, in the world of anthropology, but people spend years mining the data because you don't quite realize what it is you've got. There's always something new to learn from your data, I think. So yeah. I don't know if that's advice or just a rambling comment, but yeah, there you go.
Jenna, thank you so much. If anyone wants to keep on sending questions, I will make sure that Jenna gets them one channel or another. And Jenna, thank you so much for a very interesting talk. Please join us for the next seminar next month, and we will see you later. Bye.